and welcome to the MedEClasses postgraduate lecture series on acquired hypothyroidism. Over the last 2.5 years, we have been working on different modules related to pediatric endocrinology, and the PG lecture series has covered many like growth, calcium, electrolyte, along with thyroid and pubertal disorders. So we are going now towards acquired hypothyroidism. And acquired hypothyroidism is one condition which is quite common from a pediatric perspective and something which has significant implications in terms of short and long terms from different aspects, not just growth, but puberty, but many other issues. It can also be a cause of emergency, as was seen in this case. This was a 12-year-old boy who had presented to us with poor school performance. And at that point of time, he was found to have a low FT4 and a TSH of 9. At that point of time, the treating physician considered that this is a hypothyroidism. It's more likely to be a primary hypothyroidism because TSH is slightly high, and started on thyroxine. But within a couple of weeks, the child developed hemodynamic instability and shock. And what really went wrong here was that there was an erroneous assessment in terms of thyroid function. In that, when we remember that whenever the FT4 levels are low, we expect the TSH levels to be very high. If they are not high, this suggests a central hypothyroidism. So this was a central hypothyroidism with associated multiple pituitary hormone deficiency, which was missed and resulted in this abnormalities in terms of treatment. So clearly, this is one condition which is quite common, but often can cause a lot of confusion in that perspective. So this is a rare form of acquired hypothyroidism. We'll be discussing a lot about this in that regards. All of you can go and have a look at our website learning.growsociety.in, which has got multiple sources and resources regarding pediatric endocrinology, our e-learning platform, our courses which are there, along with our fellowship and pediatric endocrinology for postgraduate courses. We run a number of activities every month, including this PG lecture series, grand rounds, and journal clubs. And we have multiple publications ranging from pediatric endocrinology protocol to basic and advanced pediatric endocrinology. And our app provides comprehensive assessment of pediatric endocrine disorders, including thyroid interpreter, which is also available. So today we're going to focus about acquired hypothyroidism. And before that, we need to understand a basic physiology. So we all know that the hypothalamic thyrotropin releasing hormone, which is one of the smallest hormones, it has got only 3 amino acids, goes and acts on its receptor in the thyroid, in the pituitary to produce TSH, which acts on its own receptor, TSH receptor, which is basically a GNAS mediated pathway, resulting in production of T4, which essentially is a prohormone. This T4 has to be activated in the target tissue via monodiagonase 1 into T3. There is also a certain amount of T3 which is also produced by the thyroid gland directly. So what we need to remember is that while most T3 peripherally is coming from the conversion of T4 to T3, around 20% may be coming from the thyroid itself. So if you have somebody who has athyrosis, if you keep your thyroid levels, T4 levels in the normal range, your T3 may not be high enough. So that's why you want to keep your T4 in the high normal range in the treatment of somebody who has got no thyroid gland at all. Now, this T4 is bound to TBG to a greater extent, and T3 is also bound to TBG. So the free form is only 0.3 to 0.03%. So vast majority of the thyroid hormone which we are measuring are actually the total hormone, and they are not good reflectors in terms of the actual thyroid status. And in conditions where thyroxine binding globulin may be affected, like pregnancy, like estrogen exposure, like liver disease or nephrotic syndrome, we should actually go ahead and do a free thyroid hormone assessment from that perspective. Now, thyroxine, which I'll talk a bit later about how it works, goes into the cells using a MCT8 pathway, acts on the thyroid receptor to cause its function, and this is going to suppress the TSH receptor levels. So the first thing to happen in somebody who has a problem in the thyroid or primary hypothyroidism is the elevation of TSH level. This will be followed by decrease in T4. The body will try to keep the T3 levels normal by increasing the monodiagonase activity. So the T3 fall will be the last one. So T3 is the least important or most useless test in the assessment of primary hypothyroidism. In somebody, on the other hand, if there is a central hypothyroidism, like the first case which I discussed about, therein your FT4 levels will be low, but the TSH levels will not be that much high. And this is, although they should be actually zero if we talk about central hypothyroidism, but we do see that the TSH may be marginally elevated. But that TSH will be inappropriately normal for somebody who has a hypothyroidism. So anybody whose T4 is low, TSH should be very high. So if even if you have a detectable TSH or TSH is going above 10 or something, you start thinking that this could be something else in that perspective, and central hypothyroidism should be suspected in that regards. Now we know that thyroid is a group of glycoprotein hormones. So there is a post translational glycosylation which happens, and structurally it has got two basic polypeptide chain, the alpha chain and the beta chain. The alpha chain is structurally similar to other hormones like LH, FSH and HCG, causing an overlap, while the beta chain provides them specificity. So what you can see is that the TSH can act on the LH receptor, it can act on the FSH receptor and on the HCG receptor. The predominant effect of TSH is on the FSH receptor. And similarly, HCG, if the levels are very high, they may act on the TSH receptor to cause thyrotoxicosis from that regards. So if your TSH levels are very, very high, it may act on the FSH receptor, resulting in development of large ovarian cyst with peripheral precocious puberty, which is known as von Wieck-Grumbach syndrome in that regards. In the testis, this TSH will also going to work predominantly on the Sertoli cells, not much in the Leydig cell, causing macroorchidism without pubic hair. So somebody who comes to you, a boy who comes to you with large testis, but is prepubertal, think hypothyroidism. A girl who comes to you with precocious puberty and short, think hypothyroidism in that perspective. Now, placenta produces a lot of HCG, and during pregnancy in the mother, this will act on the TSH receptor to stimulate the thyroid, producing a thyrotoxicosis-like state. And this clearly can also have an effect from that perspective. So this overlap is there from that regards. I've already mentioned that only 0.003% of T4 and 0.3% of T3 is roaming around freely. Most of it is bound to binding globulin, and the most important of them is the thyroxine binding globulin TBG, which is produced by the liver, accounting for 75% of transport of thyroid hormone. Albumin also plays a role, again around 15%, ensuring a faster delivery, and transthyretin TTR is also responsible mainly for the T4 binding produced by the liver and choroid plexus. So in conditions where we have excess or deficiency of these binding globulins, there may be confusion in terms of assessment if you look at the total hormone levels in that perspective. So estrogen is going to increase the thyroxine binding globulin. So in girls who are on estrogen progesterone and somebody who is pregnant, you expect the T4 levels to be high in that perspective. So these conditions will have a high total T4, normal FT4 and a normal TSH do not need treatment. But this would have implications in terms of requirement. So do you think this is going to increase or decrease the dose requirement, Dr. Alapan?
It will increase the dose.
Why?
Free portion of the thyroid is decreased amount because of the binding globulins is high.
Okay, so you need to increase the dose. Definitely, pregnancy, the requirements will go up. Now, testosterone and glucocorticoid work the other way around. They will suppress the TBG production, and therefore they will result in a situation where your total T4 will be low, FT4 is normal, and TSH is normal. Again, no need of treatment. Very important agent, particularly heparin. Whether you're using it in vivo, like you're given heparin to somebody, or in vitro, in the capillary wherein heparin was given, that may displace the thyroid from the binding globulin and may result in a very confusing picture of high FT4 and TSH will be normal in that perspective. So, because the T4 has been displaced from the binding globulin, that's why this picture may come up. Nephrotic syndrome and chronic liver disease will also influence the albumin level and therefore result in a low level of T4 from that perspective. Now, thyroxine is a very unique group of hormones. We talk about there are protein hormones which cannot cross the cell membrane, and therefore we have got the extracellular receptor. We have got the steroid hormones which can readily cross through. But thyroxine is a unique hormone. Thyroxine is chemically what structure, Dr. Nimisha? So it's a amino acid derivative. So it is basically not a lipophilic hormone. So it cannot come into the cell. So how does it enter the cell? So not really messenger, there is a sort of a chaperone, you can say a transport protein, so MCT8, which is there, which takes the thyroxine in. So there is a specific delegation which is sent to bring, receive. So it's so important for the cell. In a very, very crude way, I can say that they're so important that they are sending somebody to receive it and bring it inside. Once in the cell, it binds to the nuclear receptor. Now remember, the steroid receptor is intracytoplasmic, it is not nuclear. Here it is nuclear, and there the receptor is usually dimerized via the retinoic acid receptor RXR. And once it binds, it will have the production of various mRNAs producing protein and the effect of that. There are multiple isoforms of thyroid receptor. So we have got the TSH, the thyroid receptor A, which is in chromosome 17, and thyroid receptor B, which is in chromosome 3, resulting in different effects of resistance to thyroid hormone. Whether A is affected or B is affected, the clinical manifestations will be different. So therefore, you have got the various units which allows a site-specific action from that regards. Now, thyroid, we all talk about head to toe, every part of the body is affected. So it affects the bone strength, and there is a specificity as to which receptor works. So alpha 1 works on the bone, increasing the strength and growth. The brain development again is alpha 1 and partly beta 1, and this is involved in every process. So neurogenesis, synaptogenesis, myelination. So right from the initial to the final stages, thyroid hormone is essential for brain function. It of course is sort of a thing which will increase the heart tone. It will cause contraction of the heart. It also has an effect on the sodium potassium ATPase and sodium calcium exchanger. So we are not talking about thyrotoxicosis here, but if you have thyrotoxicosis, you may have rhythm abnormalities, particularly atrial fibrillation, because of these conduction issues which thyroid does in that regards. It will increase the non-shivering thermogenesis. So somebody who has hypothyroidism will have more body fat from that perspective. Very important role is in the liver, where it is involved in SHBG production and lipolysis and lipogenesis as well. So even subclinical hypothyroidism may be associated with fatty liver disease because of this process. And intestine motility again becomes important. So every part of the body, this may be affected. It is expressed in the muscles, especially TR alpha, causing contractility and inhibiting CPK. We know that patients who have uncontrolled acquired hypothyroidism may mimic Duchenne's muscular dystrophy, in the sense that they will have large muscles, they will have a very high levels of CPK, which may be seen in that regards. There's also a very important crosstalk, as we already discussed. So TSH acts on the FSH receptor to cause ovarian cyst and peripheral and a sort of a macroorchidism in boys. That will be the more common scenario in that regards. Very importantly, the regulation of prolactin and TSH are very, very similar. So the same hormone dopamine or same neurotransmitter dopamine inhibits both prolactin as well as TSH. The same hormone, thyrotropin releasing hormone, stimulates dopamine as well as TSH. So somebody who has hypothyroidism will have a highly elevated level of prolactin. Anybody with hyperprolactinemia, first thing is to look at is the thyroid level. Dopamine and glucocorticoid are going to inhibit the TSH, therefore causing a low level. That's why children, newborns who are in the ICU may have a falsely negative screen once you do that. Individuals who are in the ICU, they will have a low TSH causing what looks like central hypothyroidism, but it's actually a non-thyroidal illness. We'll talk about that in detail. HCG, we already discussed, starts acting on the TSH receptor, inducing a thyrotoxicosis-like state in that perspective. Very importantly, the adipocyte leptin product from there stimulates the TRH to increase the TSH. So in children with obesity, you may have mildly elevated level of TSH, which is the effect of obesity, in which we like to go, all of you to go and have a look at our website to look at different aspects of pediatric endocrinology, look at the books, the publication, the mobile apps, and we will join again in a couple of months with the subsequent aspect